So I would thank ISCCM for giving me this opportunity. So let us learn about nursing care of a patient in acute liver failure through a case vignette. So here is a clinical vignette. Here is a 28-year-old lady with no comorbids presented with fever for 5 days, followed by jaundice for 4 days and altered sensorium for 1 day. In their past history, there is no history of any liver disease or drug abuse. On presenting vitals, heart rate is 62, BP is 122/78, and her GCS is E2, V1, and M5. Her both pupils are 3 mm and reacting to light. On room air, her saturation is 98%. So if you look at it, there is fever for 5 days and jaundice for 4 days, and with altered sensorium since 1 day. So what does this point out? The history point out. Let's also see at the labs. Her TLC is 8,000, hemoglobin is 12, platelets are normal, and there's a gross derangement of her liver function test. Her bilirubin is 3.5, which is elevated. Her enzymes, SCOD, SGPT are around in thousands. Albumin is 3.1. Her INR is also 3. RFT and electrolytes are normal. There is hypophosphatemia, 1.8 mg per deciliter. Ammonia is very high. It is 301. And looking at her viral markers, anti-hepatitis A, IgM is positive. Urine pregnancy test, tropical fever, echo, these are all negative. Her ABG shows high lactates. So these are the lab findings. Putting together her history and lab findings, our working diagnosis would be acute liver failure. This patient had an acute onset of illness with fever, altered sensorium that we call encephalopathy, and jaundice that is medically called icterus, with elevated liver enzymes and deranged coagulation parameters. Her INR is 3.2, her procal is, her PT is 52. So with encephalopathy, jaundice, and coagulopathy, she landed in acute liver failure. And the reason for acute liver failure being hepatitis A IgM marker being positive. So the first question.
Yeah. Let us keep the session interactive. We will be having questions in between. So everyone please be attentive and try to type your answers in the chat box. The first question is, all of the following are usually the features of acute liver failure except. Is it jaundice, encephalopathy, coagulopathy, or ascites? Please type your answers in the chat box. So it's a simple question. What are the features of acute liver failure? Acute liver failure and not chronic. That's the clue. People are typing coagulopathy. Usually coagulopathy is seen in acute liver failure. That is a major factor which helps in deciding further or prognosticating the patient. So that's not the answer. Come on, everybody, keep typing answers. Okay, so the answer is ascites, D.
Thank you, ma'am. Yes. So the definition for ALF include evidence of coagulation abnormalities with INR greater than 1.5 and altered mental status, that is encephalopathy, in a patient without pre-existing liver disease. There should not be any pre-existing liver disease. There should be new onset coagulopathy and altered mental encephalopathy in a patient who doesn't have a pre-existing liver disease. And the duration is also important here. Less than 26 weeks should be the duration, illness duration, because more than 26 then again goes into a chronic liver disease. So as we know, as the last question, the answer is ascites, because jaundice, encephalopathy, and coagulation abnormalities are all the features of acute liver failure, but not ascites. So why is it important to classify acute liver failure? So the acute liver failure has been classified by various systems like O'Grady systems, Brinard system, and Japanese system. Here, the most commonly used is O'Grady system. It is divided into hyperacute, acute, and subacute into 3 stages. From the onset of jaundice to encephalopathy, if it is 1 week, then it is hyperacute. From onset of jaundice to encephalopathy, if it is 4 weeks, then it is acute. Onset of jaundice to encephalopathy, it is 12 weeks, then we call it a subacute system, subacute acute liver failure. So why it is important to classify this ALF into acute, subacute, hyperacute liver failure? Because the classification helps to risk stratify and prognosticate patients. And also the probability of cerebral edema is very high with hyperacute liver failure. The patient whoever is coming with jaundice to encephalopathy with less than 1 week duration, they are called hyperacute. And these people have very high probability of cerebral edema. These people will have a very severe presentation, clinical presentation, but the survival chances are also equally good in hyperacute liver failure. So it is always very essential that we classify the patient into hyperacute or acute or subacute liver failure, because it helps us in prognostication and also risk stratification.
And the next question is, which of the following is not a cause of acute liver failure? Is it hepatitis, autoimmune causes, alcohol, or drugs? We need more participation. Please type the answers, whatever you feel is correct. It's a learning process. Everybody does mistake. That's okay. If it is wrong, that's okay. That's a simple question. There's a niche over there. Is it hepatitis, autoimmune, alcohol, or drugs? I can see some correct answers. Yes. Answer is alcohol.
Yes. Once we classify liver failure into acute, hyperacute, subacute liver failure, it is very important to know the etiology of liver failure. Once we identify the etiology, then we can initiate the proper treatment in that direction. So, to remember the causes of acute liver failure, there is a mnemonic A, B, C, D, E, F, G, H, I. So, A includes acetaminophen, hepatitis A, autoimmune hepatitis, Amanita phyllars, it's a kind of mushroom. So, mushroom poisoning and adenovirus. B includes hepatitis B, Budd-Chiari syndrome. C is cryptogenic and hepatitis C, cytomegalovirus. D, hepatitis D, drugs and toxins. E, hepatitis E and Epstein-Barr virus. F for fatty infiltration, acute fatty liver of pregnancy, Rh syndrome. G stands for genetic diseases like Wilson disease. H includes hypoperfusion of the liver, especially ischemic hepatitis, which occurs mostly during sepsis. HELP syndrome, heat stroke, hemophagocytic lymphocytosis. I is infiltration by tumors. So these are the causes of acute liver failure. What is the pathogenesis of acute liver failure? One, we have learned about the different kind of etiologies of liver failure. One, there is an etiological agent that causes massive destruction of the hepatocytes. The massive destruction of the hepatocytes triggers massive inflammation, which drives vasoplegic circulatory shock. There is both pro-inflammatory and anti-inflammatory cytokines that are released into the systemic circulation, which causes systemic inflammatory response syndrome, which later leads to multi-organ dysfunction syndrome. So this is the pathogenesis of liver failure. So what are the clinical features? If you have to look at the clinical features, the most important being encephalopathy, the brain, how it get affected, hepatic encephalopathy, cerebral edema, and raised intracranial pressure. These are the main clinical features of the central nervous system. If we look at the liver, there is loss of the metabolic functions of the liver, especially gluconeogenesis is gone. So the patient will have hypoglycemia. Lactates clearance, which is usually done by liver, is now lost. So there will be lactic acidosis. Ammonia clearance is affected, which resulted in hyperammonia. And synthetic capacity is also gone. So factors 2, 7, 9, 10, which are the main coagulation factors, are usually produced by liver. In a failed liver, these factors are not produced, so this results in coagulopathy. Apart from that, ARDS from the lungs and heart includes high output state of the heart, pancreatitis, adrenal insufficiency, AKI, bone marrow suppressions, and immunoparesis. So the patients will be more prone for infections. portal hypertension, and SIRS response. These are the different clinical features that happens in a patient with acute liver failure. So management of an acute liver failure in ICU. How do you manage? Most importantly, as soon as we receive the patient to ICU with an ultrasound, we do the POCA scan, look at the effusions, look at the collections in the abdomen, everything. Once the POCA scan is done, the first and foremost step is to nurse the patient in a very quiet and calm atmosphere, because any small trigger can raise his patient's ICP and leads to further damage of the brain. So it is always prudent that we maintain a very quiet and calm atmosphere, like switching off the lights, like silencing the monitors, multiple beeping of the monitors. Those are the small, simple steps that doesn't trigger the CNS of the patient. So quiet and calm atmosphere is more important. As always, airway, breathing, circulation. Airways also, we have to intubate, rapid sequence intubation by a quick and experienced critical care physician or anesthesiologist. Multiple attempts of intubation raises the intracranial pressure. So it is always warranted that the person, whoever is intubating, is little experienced and does it without multiple attempts. And also the drugs that increases the intracerebral pressure, like ketamine, should be avoided during securing an airway. Breathing, lung protective ventilation, and it is we have to maintain normocapnia, normooxemia, and normal ETCO2. Circulation, we have to target a map of 65 mm of Hg. Hypoglycemia, as we have seen in the clinical features, gluconeogenesis is gone when liver failure occurs. So patient usually lands in hypoglycemia. It is very essential that we monitor sugars every second hour. Electrolyte correction, especially phosphates. Phosphates, hypophosphatemia, hyponatremia, any disturbances in electrolyte should be corrected. NAC infusion, N-acetylcysteine infusion, it helps in regeneration and liver regeneration. So it should be started at the earliest. Anti-edema and anti-encephalopathy measures to decrease the ammonia should also be started. Coagulopathy correction with the help of vitamin K or blood products like fresh frozen plasma, we have to start them. Antibiotics, antifungals, as per the cultures and patient's condition, we have to decide and start. And also early enteral nutrition, Riles tube or with anything, we have to start the early enteral nutrition. Okay, targeting a calories of 50 kilocalories per kg per day and a protein of 1.5 to 2 grams per kg. Apart from the routine fast hug buds like feeding, analgesia, sedation, thromboembolism prophylaxis, head and elevation, ulcer prophylaxis, GRBS monitoring, bowel and bladder movement, invasive lines. We have to check if there is any bleeding from the invasive line site. And also we have to see if there is any de-escalation of antibiotics, we have to do at the earliest. Monitoring, our monitoring mainly includes neurological, different systems we have to monitor. Most important is the neurological monitoring, because acute liver failure patients, they land with cerebral edema because of high ammonia levels. This cerebral edema leads to increased intracranial pressure and intracranial hypertension, which later leads to brain herniation and brain death. So it is very important that the neurological monitoring of acute liver failure should be done at a regular intervals, and it should be monitored continuously. Apart from that, the coagulation abnormalities because of the decreased production of 2, 7, 9, 10 factors by the failed liver, patients land in bleeding manifestations. So it is very important that the sisters keep monitoring bleeding from the rectum, or bleeding from the Riles tube, or bleeding from any central line side or any line side, that they have to monitor continuously. And also these people are very prone for infections because of the immunoparesis. So highly aseptic precautions should be maintained while handling the patients with liver failure. And also metabolic hypoglycemia, as we already discussed, that's the most common thing. So we need to monitor the sugars, and hyponatremia, hypophosphatemia, hypokalemia, and hyperlactatemia. Liver clears the excessive lactates from the body. So in a failed liver, the person lactate clearance is not done properly. So the lactate level goes up. So we have to monitor the lactates continuously. And also the acute renal failure is very common in a patient with acute liver failure. So urine output monitoring should be done and those should be documented. How do you monitor the CNS, central nervous system? This is through West Haven criteria. West Haven criteria, it has got total 5 stages, stage 0, 1, 2, 3, and 4. Basing on that, it is very important that even the patient stage changes by even one stage, the patient hepatic encephalopathy worsens, that is gives a very poor prognosis. So stage 1, patient will have a very shortened attention span. In stage 2, patient will be lethargic, slight disorientation. Stage 3, patient will be somnolence with gross disorientation. Stage 4 is coma. So the bedside nursing sister should always keep an eye and monitoring the hepatic encephalopathy, the CNS status of this patient. Whether the patient is stage 1 or stage 2, stage 3, they should always keep monitoring the stages of this patient. And if any worsening of the stage, if any worsening of the clinical neurological stages, that should be immediately notified to the concerned doctor.
So our next question is, which of the following is used to identify acute liver failure patients' eligibility for liver transplantation? So once the patient is into the ICU, you have diagnosed him as ALF. Now is the patient a candidate for liver transplantation or not? So what is the criteria used to assess that? Is it West Haven criteria or a Glasgow coma scale, King's College criteria, or a Ranson's criteria? So which of the following is the answer? Please type in the chat box. So the question seems to be simple. Just now you have heard about the West Haven criteria. So it is used to assess the sensorium or grade of encephalopathy. Yes, I can see some answers, correct answers. On Glasgow coma scale is used to assess the sensorium. We have 3 components in it: eye response, motor response, and verbal response. Other thing is the King's College criteria and Ranson's criteria. Yes, I think most of them are getting the right answer. It's King's College criteria.
So now we have a case of acute liver failure. It is a hyperacute liver failure, and we try to manage the case CNS by the system wise, and we have tried to airway breathing circulation. In the same setting, it is very important to assess if the patient is fitting for an emergency liver transplantation. There is a criteria, King's College criteria, which will tell us, which will guide us whether this patient who landed up in ICU with acute liver failure would require a liver transplantation or not. So this assessment and should be done in the initial setting immediately. As soon as once we stabilize the case, we should start. Once we get the labs, we should assess if this patient is fit for liver transplantation or not. If he is fit for the liver transplantation, we have to notify the transplant team immediately, and also we have to make sure that they are a part of the treating team as well. So the King's College criteria, they have divided into 2 types. Liver failure, if it is because of paracetamol, is under one side, and liver failure with causes other than paracetamol poisoning. In our case, it is ALF, not due to paracetamol poisoning. Here it is hepatitis A related acute liver failure. So we stand on the right side of this table. So in our what is the major criteria in ALF not due to paracetamol poisoning? It is INR greater than 6.5. Or then minor criteria, you should have at least 3 out of this 5 criteria. These 5 criteria include etiology, indeterminate etiology, or hepatitis or drug-induced hepatitis, age less than 10 or greater than 40, interval of jaundice or encephalopathy is greater than 7 days, bilirubin greater than 300 micromoles or greater than 70 mg per deciliter. INR is greater than 3.5. If it is ALF due to paracetamol poisoning, the arterial pH less than 7.3 after adequate fluid resuscitation, or lactates greater than 3, or 3 out of this 3 criteria should be there. Hepatic encephalopathy grade 3, serum creatinine greater than 300 micromoles per liter, or INR greater than 6.5. Our case, it is acute liver failure because of hepatitis A, and the INR of the patient is 3.5. So INR ideally it should be greater than 6.5. So she's not fitting into the transplant criteria. Let us see the minor criteria if there are any 3 out of 5 criteria. Etiology, we have hepatitis etiology. Age is 28 years, so it is not there. Interval of jaundice encephalopathy is less than 1 week, so here it is greater than 7 weeks, that is also not there. Bilirubin is around 4, here it is greater than 17. INR is greater than 3.5. So we have only two out of 5 criteria. So she is not fit for immediate transplantation. To summarize, here it's a 28-year-old lady, hyperacute liver failure, hepatitis A related, and she is having grade 4 encephalopathy as per West Haven classification that we have just now seen. Coagulopathy, yes, her INR is deranged, but there are no clinical signs of bleeding, and it's a severe hepatitis, and she has dyselectrolytemia, that is low phosphatemia.
So our next question is, which of the following is a good prognosticator in acute liver failure? Is it hypophosphatemia, hyponatremia, hypernatremia, or hypocalcemia? What do you think is the correct answer? Type it in the chat box. So Dr. Kalyan has elaboratively said, and he's repeated this a number of times, I think, till presentation. This is one good prognostic factor which tells us that the patient has a good chances of survival. I can see a few answers: hyponatremia, few answers hypophosphatemia. Good, hypophosphatemia. So what happens here is regenerating hepatocytes usually consume phosphorus in regeneration of the hepatocyte. That is the reason the patient will land up in hypophosphatemia. So the answer is hypophosphatemia. It is one of the mechanisms. Hypophosphatemia is a good prognostic factor in acute liver failure, and vice versa. Hyperphosphatemia tells the prognosis is going bad. Whereas others, hyponatremia, hypernatremia, and hypocalcemia should also be corrected, but they have no significance in prognostication. Answer is hypophosphatemia.
Yes. So let us see. Let us now analyze the different complications as the case progresses. We'll get to know what are the complications that this patient is landing into. So as a course of illness, that we are treating the patient, and what's happening now. Let us see. The patient developed generalized tonic-clonic seizures, but the pupils are 3 mm and sluggishly reacting to light. So what do you think the cause of this illness? Because of hyperammonia, and that is causing the raise changes in the serum osmolarity, which is leading to cerebral edema, that is causing this patient generalized tonic-clonic seizures. So usually we treat such things with 3% NS versus mannitol. Ideally 3% NS is preferred agent, but if the sodium levels are already above 155, it's better we avoid 3% NS. Mannitol can be given, but it causes renal failure. Already the patient is in renal failure, it's better to avoid mannitol. So basing on the patient condition, we can either give 3% NS or mannitol, and that will decrease the cerebral edema. Apart from that, the patient is seizing, so you will require anti-epileptics, lorazepam, and Levipil. So the neurological monitoring, what can a bedside nurse, how can she monitor in an acute liver failure neurological status? First thing, total Glasgow coma scale. As well, apart from the West Haven classification, the other things what they can do bedside is to look after the Glasgow coma scale. It's a 15, maximum score is 15. If there is any drop in his score, then that is an also alarming sign. Apart from that, optic nerve sheath diameter, that can be measured through an ultrasound. Once we usually one optic nerve sheath diameter greater than 5 mm, it reflects that the patient is landing into cerebral edema. And pupillary asymmetry, it's a very simple test that the sister can do bedside. Monitoring the pupils bilaterally every hourly will guide us about if there is any asymmetry, if there is poor reaction to light, or if especially the size of the pupils, if they differ, then that will guide us about the cerebral edema part. Apart from that, CT brain, and also clinically, if there is any seizure activity, that also helps us to identify cerebral edema. Acute liver failure patients are at risk of cerebral edema and raised intracranial hypertension because of raised ammonia. So how do we recognize intracranial hypertension? Abnormal pupillary reflexes, clinical seizures, muscular rigidity, and decerebrate posturing, all this point out towards high or raised intracranial pressure. So if you look at these graphs, these are the pressure time graphs. These are the ICP graphs. So usually it will have three components, P1, P2, and P3. Whenever the P2, ideally the P1 should be higher than P2. But if P2 becomes higher than P1, then that shows that the patient is having raised intracranial pressure. So the second graph here, P2 greater than P1, that points out toward raised intracranial hypertension. So we need to maintain an intracranial pressure of less than 25 mm of Hg and cerebral perfusion pressure of greater than 50 mm of Hg. By maintaining these pressures, we can optimize the intracranial hypertension. So cerebral edema, most common cause of death in acute liver failure is cerebral edema, and intracranial, which leads to intracranial hypertension, ischemic brain injury, and brain herniation, and finally brain death. So one of the most important risk factors for cerebral edema in acute liver failure is hyperammonemia. And in our case, the patient's ammonia is already 300, so that's quite high. Other risk factors being hypoxia, hypotension, and poor cerebral perfusion pressure. All these things leads to cerebral edema by causing astrocyte swelling. Because of the hyperammonia level and the neuroinflammation, the astrocytes in the brain, they get swollen, which causes cerebral edema. And high the cerebral edema or intracranial pressure, high the chances of mortality.
The next question is, lactulose can decrease the level of ammonia in the blood by option A, decreases colonic transit time, B, reducing the opportunity for absorption of gut-derived ammonia by purgative effect, C, decreases colonic pH and prevents production of ammonia by gut urea lysis, and option D, all the above. Please type your answers in the chat box. I think the question is very clear and basic. What is the mechanism of action of lactulose, which helps in decreasing the level of ammonia? What does the lactulose do? We, on a routine basis, as a part of anti-encephalopathy measure, we use lactulose to help patient move his bowels, aiming at least 3 times per day of bowel movement is important in a patient with either it's an ALF or an ACLF patient to prevent encephalopathy. So I can see some answers. D, yes. The answer is very simple. It is just the lactulose. It is reducing the production, reducing the absorption, increasing the elimination. That's the simple thing the lactulose does. So answer is all the above.
Yes. We know that because cerebral edema, hyperammonia is one of the causes for cerebral edema, and to decrease the ammonia levels, we target greater than 4 stools per day. For 24 hours, the patient at least has to pass 4 stools. Through that mechanism, and lactulose will help the patient to pass those greater than 4 stools per day. That will decrease the level of ammonia and also cerebral edema. So non-invasively, how can we monitor the intracranial pressure? As I told you, optic nerve sheath diameter is one that can be done with an ultrasound and continuous EEG monitoring, and also transcranial Doppler. Same, with the help of ultrasound, they monitor the arterial pressures in the brain, and also pupillarimetry, CT head, and MRI brain. These are all the non-invasive methods where how we can monitor the raised intracranial pressures. So if you see this is a vascular probe that is put on the orbit of the patient. Once we put that probe, the image that flashes is a globe followed by the optic nerve sheath. So 3 mm from the globe, we have to measure this optic nerve sheath diameter. And if the optic nerve sheath diameter is greater than 0.5 centimeter, it points towards cerebral edema. So this is a simple bedside test that can be done. It gives us an idea about the cerebral edema status of the patient. And also, if we have to looking at the invasive options, how do we monitor the intracranial pressure? The disadvantages of invasive pressure monitoring, cerebral pressure monitoring would be they add to the infection, because ALF patients are also at the risk of infections. In any invasive procedure will increase the risk of infection, and also these patients are coagulopathic, they bleed a lot. So putting some lines into their ventricles and all, they bleed a lot. So invasive option is not an ideal one, but there are the ways we can do ICP monitoring invasive also, like intraparenchymal, epidural, subdural. We place these catheters and attach them to the transducers, and the pressures will be more, displayed on the monitor. So by invasive monitoring, we can accurately measure the ICP pressure. As we already discussed, the ICP pressure should be less than 25 mm of Hg, and cerebral perfusion should be greater than 50 mm of Hg. So how can we decrease raised intracranial pressure in a patient of acute liver failure? Bedside, it is very essential that the head end of the bed is elevated for 30 degrees, not more than 30, or not, patient should not be made like flat down. So 30 degrees is ideal. And also avoid unnecessary stimulation like frequent suctioning of the patient. And also quiet and calm atmosphere is more important. Apart from that, control lung protective ventilation with adequate sedation and paralysis. Normoxemia, normocapnia, normothermia, all these simple steps will decrease the patient intracranial pressure. And also, as we discussed, anti-edema measures 3% NS and mannitol, basing on the patient's condition. If we are using 3% NS, then the sodium target would be 155. Like less than 155, it should not go beyond 155. If we are using mannitol, make sure that the patient doesn't have renal failure.
So our next question is, nursing neurological monitoring for raised ICP or cerebral edema should look for the following signs. So the question says, being a nurse, how do you neurologically monitor a patient? Taking what are the aids you do? Option 1, pupillary size and reactivity. Option 2, seizure activity or twitching. Option 3, Glasgow Coma Scale or posturing. Option 4, Cushing's triad. Option 5, all of the above. Please type your answers in the chat box. So using what, which of the following you monitor the patient's deterioration, and how do you early identify the patient's deterioration, which is most important in a patient with acute liver failure, because when we prevent complications, that is the point the patient will have good prognosis. If the patient once lands up in complications, it is meaning that we have missed the train. So what is the answer? Yeah, I think few of them are getting right. So how do you neurologically monitor? We use all these aids. By looking at the Glasgow Coma Scale, we also monitor the pupillary size. Any difference in the pupillary size, or anisocoria it is called, that says there is an intracranial bleed. Maybe the patient had coagulopathy and now the patient is present with intracranial bleed. Any history, any evidence of clinical seizures will also say that there is some intracranial hemorrhage happening. And using a Glasgow Coma Scale, even 2 points drop in the GCS score has a poor prognostication. And Cushing's triad. Cushing's triad is seen in the late phase where there is increased high ICP and all. So the answer is all of them.
Yes. So we have seen and we have learned how to neurologically monitor a patient an acute liver failure. So these are all the modalities what we can do at the bedside: pupil size, seizure activities, scorings like West Haven score, Glasgow Coma score, and non-invasive and invasive methods of monitoring ICP. So these are the methods how do we monitor ICP, and we have to take all proper precautions to not to increase the intracranial pressure. Okay, and at the same time, The reason for raised intracranial pressure is hyperammonia, and we have to aim and target so that the ammonia level in the blood remains normal by various medical management. Okay, so as the case is in the course of illness, the patient now has INR of 6. It was initially 3.2 before, and APTT is greater than 100, and platelets are 1.2 lakhs, and there is a clinical signs of bleed like melena parrectum. And so what would be the treatment in such cases? Usually whenever the patient is having a deranged coagulopathy, that is manifested, but whenever you place a Ryle's tube, you see blood coming out of the Ryle's tube, or whenever the patient passes motion, the sister has to see the color of the stools, how if it is black color or blood, what is the type of stool that is. And usually the treatment would be to start an immediate proton pump inhibitors like pan infusion, and also to give the blood products to correct the coagulopathy. So how do you choose and transfuse these blood products rather than randomly giving multiple blood products? It is very prudent that we there are certain tests which we can do, and we can direct we can give the proper blood products rather than giving PRBCs blindly. So how do we do that? With the help of a thromboelastogram. It is a technique where the patient blood is sent, and it is sent for the analysis. We get a graph like this. Usually we get a graph like this. It has got multiple components in that text. It includes like R time, K time, angle, maximum amplitude, and lysis 30. Lysis 30. So in fact, this total tech represents the the coagulation dynamics will be plotted against as a graph on this in a text. So the R time usually is around 11 minutes, K time is around 3 to 4 minutes. So whenever there is an increase in R time, it means that patient requires FFPs, like fresh frozen plasma. When there is an increase in K time or a decrease in angle, he would require different types of blood products. And when there is a decrease in maximum amplitude, patient requires platelets. And lysis 30, if it is high, then we need to give tranexamic acid. So basing on R time, K time, angle, and also lysis 30, we have to decide what to be given rather than randomly giving him multiple products, blood products, and that which usually causes rally and tacho. So, and volume overloaded state. And apart from that, the coagulopathy can also be corrected by using PLEX. PLEX is a process where we take out the patient plasma, and we give external fresh frozen plasma to it. And by doing the PLEX, basically the inflammatory response, we remove all the inflammatory markers that is affecting the hepatic microenvironment and also the systemic circulation. We remove all those molecules, and helps in by giving extra plasma. We also correct the coagulopathy, and by doing PLEX, the patient the bilirubin also comes down. So now after correction of the coagulopathy, the other complications, what else complications can a patient with acute liver failure can experience? Here, as the case is progressing, the patient TLC now went up to 25,000, and the blood pressure is 80/50, and the lactates are 9.5. So high lactates, low blood pressures, and high TLC count, all these things pointed towards an infection. So usually whenever the patient is presented this way, initially we would resuscitate him with some fluids, isotonic solutions, and also albumin. And if the patient's BP is so low, he would require invasive hemodynamic monitoring to secure an arterial line, and also immediately start off on vasopressors like NORAD is the vasopressor of choice. We start to increase the blood pressures. If the pressures are falling further down, if there's a requirement of more than one vasopressor, maybe we need to add stress dose steroids. And also to identify the reason for this drop in hemoglobin, we need to find the source of infection. So it is essential that we send the surveillance cultures, blood, urine, ET cultures if it gets intubated. If I said all these things we have to, all these cultures should be sent. Sepsis infections occur more in 55 to 90% of the patients with acute liver failure, and they are one of the most common causes of death in such cases of acute liver failure. All this happens because damaged liver causes immune paralysis, so they are more prone to infections. Infections like pneumonia, urinary tract infections, intravenous catheters, lines-related infections, spontaneous bacterial peritonitis, fungal sepsis, all these are the poor prognostic signs, and they increase the mortality. So how can we prevent these infections in a patient with acute liver failure? And these 5 steps of hand hygiene, I think not just in liver failure case, in any case that we see in ICU, these should be the first and most important steps that go a long way in controlling the infections, especially in ICU. These 5 steps of hand hygiene: before touching the patients, after touching the patient, before doing procedure, before touching the patient, after touching the patient surroundings. We have to follow these 5 steps to minimize the infections, especially in ALF patients, and also in all cases that are in ICU. And apart from that, the patient is intubated, ventilator VAP bundle to prevent the ventilator associated pneumonia. These are the steps of the VAP bundle should also be followed. Apart from that, if the patient is having central lines or urinary tract catheters, the Corti bundle and Clapsy bundle, they all should be followed religiously. And because these patients are at high risk of getting infections, so with these simple bedside techniques, with this different steps that are included in this various VAP bundle, Corti bundle, Clapsy bundle, and hand hygiene steps, we can control infections in these patients. So as the course of illness is progressing, now we notice to have there's a decrease in urine output of patient. Initially, the urine output was good, but there is sudden drop in urine output. It is less than 0.5 ml per kg per hour, and the creatinine is also rising. It is 2.1 now. And the ABG showed metabolic acidosis with a pH of 7.1, bicarb 16, PCO2 is 40, and lactates are 9.5, quite high. So what could be the causes of acute kidney injury in a patient with acute liver failure? So the causes could be sepsis. Infections can cause infection, urinary tract infection can cause decrease in urine output and AKI. And also if we are using drugs like mannitol, as we already discussed, mannitol can cause renal failure. And also pre-renal causes, if the patient is not adequately fluid resuscitated, if they're still persisting of hypotension, then the kidneys perfusion will be decreased. That can cause pre-renal failure. So what should be the treatment in such cases? We have to adequately volume resuscitate the patient. If there is any sepsis and all, early identification of the infection, proper antibiotics should be given. AKI is most commonly associated in patients with paracetamol overdosing. So the paracetamol-induced liver failure, these patients mostly land in AKI, and that's a very poor prognostic sign. And other risk factors include older age patients have more chances of AKI, hypotension requiring vasopressor support, sepsis, and CIRS response. All these things causes AKI in patients with acute liver failure. And how do you treat AKI in a patient with acute liver failure? Continuous renal replacement therapy. CRRT therapy is the preferred mode of dialysis in patients with acute liver failure. Because acute liver failure patients have cerebral edema, any rapid or dynamic shifts in the fluid can worsen the cerebral edema, leading to brain death. So CRRT, continuous slow renal replacement therapy over 24 hours time. That this is done at a very slow pace. This mode decreases the ammonia slowly over a longer duration of time, which causes less fluid shifts and less cerebral edema. So CRRT is a preferred mode, especially in patients with acute liver failure who are at high risk of cerebral edema and neurological damage. Apart from supportive care to the liver, there are other methods also, like extracorporeal liver support measures, which includes molecular absorbent reticular system and detoxification therapies such as single pass albumin dialysis. These are the different extracorporeal liver support therapies that can be employed when the liver is completely not working. these are other techniques where we can support the liver till the patient reaches the transplant, or till we can bridge them to the transplantation by using this extracorporeal liver support measures. So after seeing the different complications like sepsis, coagulopathy, hepatic encephalopathy, and AKI, let us see on etiological basis how can we treat liver failure. So as we already read the mnemonic ABCDEF, which points out the various etiologies of liver failure. Let's see one by one. Hepatitis A, hepatitis E, hepatitis B, herpes. These are all viral infections, so they require antiviral medications, supportive care, and also whenever the patient with these viral infections come with those complications, we also learn how to deal with those complications. And cytomegalovirus, we give ganciclovir. Herpes virus, we give acyclovir. Wilson's disease, we can we can do plex and then take him for the liver transplantation. Autoimmune hepatitis, early liver transplantation, and steroids at a dose of 60 mg per day. Fatty liver of pregnancy, early recognition is more important, and delivery of the fetus. And if any worsening, liver transplantation. Mushroom poisoning, gastric lavage, activated charcoal, intravenous for the mushroom poisoning, intravenous penicillin G at a dose of 1 million unit kg per day is also administered. So paracetamol poisoning is one of the most important cause of acute liver failure, maybe not in our country, but in the Western world. A toxicology screen and determination of the paracetamol level are necessary in every patient. If a person takes 10 grams per day, an acute consumption of 10 grams per day is harmful, or a chronic dose of 4 grams per day. If a chronic staggered dose of 4 grams per day, then that is also causes acute liver failure. So how can, once a patient comes to the hospital, activated charcoal, if the consumption, if it is less than 4 hours after consumption of the acetaminophen, and also NAC infusion is very essential. The patient presents with raised serum aminotransferases and coagulopathy, hepatic necrosis. All this leads to acute liver failure, and we have King's College criteria, which shows the major criteria being pH less than 7.3. If the patient falls into the transplant criteria, we immediately have to notify the transplant team and get the necessary things done. So NAC protocol, though we give orally or IV, both has got same efficacy. And oral includes a loading dose of 140 mg per kg followed by 17 doses of 70 mg per kg given every 4th hourly. Basically, the patient usually have hepatic encephalopathy, altered sensorium, so your oral route is not usually preferred because of the risk of aspiration and all. However, with the Riles tube and all, they can still be placed. And IV includes IV loading dose of 150 mg per kg over 1 hour, followed by 50 mg per kg over 4 hours, and then 100 mg per kg for 16 hours.
So our next question is on N-acetylcysteine. N-acetylcysteine is effective antidote for acetaminophen poisoning. How does it act? What is the mechanism of action? Option A. NAC replenishes the glutathione stores in the liver. Option B. NAC can directly substitute glutathione. Option C. NAC augments conversion of acetaminophen to metabolite other than NACQ1. Option D. All of the above. Please type your answers in the chat box. Role of N-acetylcysteine in paracetamol poisoning. Dr. Kalyan has just explained what protocol we follow and all. So it is good to know what is the mechanism of action N-acetylcysteine works on. I think I'm getting most of the correct answers. Yes, the answer is all of the above.
Yes, NAC is the antidote for acetaminophen poisoning. It has got various mechanisms how it will act. Overall, it replenishes the glutathione stores in the liver, the damaged liver. And other most important is yellow phosphorus, usually rat poison, what we call. So it's usually even a dose of 6 grams. We have cases where they have survived with the consumption of 6 grams, but however, it is a very lethal poison, and consumption of greater than 10 grams, I think that's a very, very high dose, and that causes death. And it is it's usually is found as a rat killer poison, the fireworks, the pesticides and match heads, and also military ammunition. 3% zinc sulfide based teas, and it gets hydrolyzed by gastric acids and releases phosphine, which causes hepatic steatosis and affects beta oxidation in the esterification of the fatty acids, and very, very, very high mortality, very poor chances of survival. And in these patients, they usually with a deranged LFT, coagulopathy, hypoglycemia. So these, and there is no particular antidote for this yellow phosphorus poisoning. Usually we support the patient during with the plex, and we see if they fit into the transplant criteria, and at the earliest involving the transplant team, and getting the transplantation would be ideal. But this has got a very high mortality. So in conclusion, any patient with acute liver failure is landing up in ICU the most, and as a bedside caregiver, as a bedside nursing system, it's very important that neurological monitoring is very pivotal. They need to look at the clinical status of the patient. They need to monitor the pupils, they monitor the GCS and the West Haven classification, and they have to make sure that the patient passes 4 stools at least in the last 24 hours, keep a track on ammonia levels, and any worsening in the neurological status should immediately be brought into the notice of the doctor or the concerned in charge sister, anybody. And hemodynamic monitoring to maintain adequate blood pressures, so that we can proper perfusion of the all organs, to kidney to the brain is proper. So hemodynamic monitoring and adequate maintaining of MAP for proper perfusion of the all other organs is very essential. And the biochemical parameters, most importantly, hypoglycemia, that should be monitored regularly. Lactate should be monitored, and hypophosphatemia, electrolytes, all those things should be properly monitored, and they give us a clue whether the patient is improving, deteriorating. Okay. And also the preventive measures, supportive care, the bedside supportive care, and identifying the etiology at the early, and also involving the transplant team by using King's College criteria. If the patient fits for the transplantation, they should be involved immediately. Prognostication, as I told you, hyperacute liver failure, they have very severe clinical presentation, but a very good prognostication. So measures should be very rapid, adequate, and proper for a better outcomes. And at the end of the day, it's a teamwork. It's always a teamwork that transplant team, sisters, doctors, all put together with a proper coordinated teamwork, we can make a patient with acute liver failure survive. So thank you for listening.
Well said, Kalyan, and well presented. To summarize, healthcare personnel, especially the nursing staff, being the first responders at the bedside, you play a prime role in identifying early deterioration in patients' condition, which has a greater impact in their outcome. If the nursing staff are the one, when they identify early deterioration through vigilant hemodynamic, central nervous system monitoring, or biochemical monitoring, and this helps us. If the patient is deteriorating, we can channelize the transplant team if the patient is a candidate for transplant or not. If the patient is a candidate for transplant, we can notify them and we can save the patient's life. Another thing is the crux of the management of the acute liver failure is early detection of deterioration, preventive measures. We have to prevent the patient landing up in complications, giving supportive care, and managing the complications, whatever arises. And as Kalyan well said, it's a teamwork. At the end of the day, it's a teamwork by which we can save many lives. And then we get a good outcome and a patient satisfaction. So that is all about acute liver failure. Any other questions anybody have? We are here to clarify. Before somebody posts any question, Kalyan, can I ask you, what are the most common drugs which causes acute liver failure, either in general or on the counter medication or the medication or the drugs which are used generally in the ICU?
Yeah, ma'am, that's a very good question, and that I think sisters or whoever, like, we should always look into the medication chart whenever the patient comes in, lands in acute liver failure. It's always we look into the medication charts, and I try to identify if there are any drugs that are causing liver injury or hepatic dysfunction. So we can, by stopping those drugs, we can prevent drug-induced liver injury also. Especially, I think in our setup, paracetamol is one of the most common used drugs for the fever and all. And also anti-tubercular drugs, especially all ATG drugs, usually almost all drugs, they have very high hepatotoxicity, and also anti-epileptic drugs, phenytoin, and also they also cause liver failure. So whenever the patient is on these drugs, it's better we monitor. Apart from that, quite some Ayurvedic medications and some other alternative source of medication are also known to cause liver failure. So these are the things that are like very common that they cause liver failure in ICU.
Yes, as you rightly said, most of the people are unaware that Ayurvedic medicine, herbal medicine, which contains maybe steroids also, they are one of the causes of the acute liver failure or acute and chronic liver failure decompensation also. So it is the time that the public should be aware, and every nursing staff, they can educate the family members saying what is the importance of not taking this all counterproductive alternate medicine, which can be a cause of acute liver failure also. Any other questions or any questions you have, please type in the chat box. We are looking forward for it. Hope everyone understood the session. We'll leave the email IDs in the chat box. Any other clarifications you want, you can contact me, Anveshi, or Kalyan. We are here. We'll reply back through emails also. Okay, thank you all for your patient listening. Okay, that's all. Thank you.
Thank you all.